Hi, good morning. I'm so excited to be here. I'm Donna Westmoreland, and I'm going to be your first presenter. I'm going to mention that I was invited. Really enjoyed working with Chuck and Rich. Dave Robinson, who is representative of Hospice of Michigan, invited me to come speak today with your group, which I think is one of the key issues facing our society. I do want to let you know that I can talk for 3 days on this topic, so Rich is going to tell me when to stop. There are usually a lot of questions and answers, but one of the things I want to highlight is Dave is the Regional Market Director for Hospice of Michigan. And one of the things, I've worked closely with him for 2-3 years now. One of the things that they have is everyone who is a representative is trained in advanced care planning. So I'm certified as a clinician, and advanced care planning is part of that, but he is a wealth of knowledge and information for advanced care planning resources. And so I want to just, Dave, wave or something. I want to introduce him as, thank him for inviting me, and just let you know that even if you have questions for me, that's great, but he's also an amazing resource that not every hospice invests in that level of training for the representatives, and take advantage of him.
Okay, give me a second. Yeah. And to answer Donna's questions, you don't have 3 days. Each one is given 40 minutes, so it's about 25, 30 minutes to present. And Q&As, please, questions to follow each presentation, okay? So write your notes if you want to. The contact information for each of the presenters is in the handout. Their email, their names, their positions, and their email addresses. So each of you then has that. Donna, she mentioned clinical nurse practitioner for Avalon Physician Services in Northville, certified in primary and palliative care. After managing senior communities as a property manager, she became passionate about the residents' health needs and became a registered nurse. While working for 4 years in Beaumont in the hospital's neurotrauma and cardiac ICUs, she became aware of how often people receive invasive treatments and CPR who may not have wanted it. After 10 years working home health nurse, educator, and administrator, focused on keeping people out of the hospital. And anybody wants to stay out of the hospital, raise your hand. Those who want to go in, raise your hand. Thank you. She became an NP, nurse practitioner, to be able to more proactively manage advanced illnesses. Current practice provides primary care house calls to the homebound seniors and palliative care when illness becomes more advanced. Her mission to help people stay out of the hospital and receive exactly the care that they want, no more, no less. Thank you.
Hey, real quick, what are all the letters after?
But we got to ask them. But she does only have half an hour.
So you're asking about my alphabet soup?
Yeah.
Yes. So Master's of Science in Nursing is my nursing degree. FNP is Family Nurse Practitioner Board Certified. And then ACHPN is the alphabet soup for it's Advanced Certified Hospice and Palliative Nurse Practitioner. So, too much? Oh, thank you. He's reminding me I can look right here, but you're over there, so thank you. So, I'm very excited to get started. I am going to stay because I want to hear what the other presenters have to say, and there are a lot of questions, and I need to learn what the other presenters have for my own patient population. So I think Dave is staying with me if you want to talk further at the end. I will be here. Thank you. We talked about this. So I think our greatest challenge as a nation, I was talking about the fact that I received my AARP invitation in the mail this year. This is the year I'm turning 50. And I think our biggest challenge as a nation is how we take care of the people who are going before us, our aging neighbors, and the people who are taking care of them. I think that's the real unsung, unsupported group in our nation. And the most impactful or impressive statistic that I throw out there from when I want to get people's attention is that we all know about the baby boomers, the silver tsunami. We hear that term over and over, but what does that really mean? It means that every year between 2010 and 2030, 10,000 people every day are becoming eligible for Medicare. And I have a 15-year-old son, and I want to help fix this problem before he has to take care of me in a broken system. And I've seen things go well, and I've seen things go badly in my own patient care experiences, and that's why I do what I do. And we can really educate ourselves and advocate ourselves and change our own experiences and that of those around us. So this is just a brief overview of kind of what we're going to be talking about. I'm just going to dive in. So my background is I spent 4 years before I was even clinical managing senior communities. They were low-income senior housing buildings, and there were no services at all. You had to be over 55 and low income. And the group I worked for, out of the goodness of their heart, hired a social worker to help deal with the human needs of aging in place without services. And I realized quickly that I wanted my work and energy to help focus more on the human side. Then I became a nurse and worked 5 years in the ICUs, where you see quite often, one of my slides coming up talks about if you don't make a decision, you are actually choosing the highest level of intervention and mechanized care, which you may or may not want. You should really understand what you're selecting, but not choosing is actually making a choice. And I learned that in the ICU. Then I became a home health nurse. And for 10 years, I was the person in the home on a Friday with someone who was about to go to the emergency room if they didn't have an order for a little bit of extra Lasix, that water pill to get rid of that extra fluid. And I'd be on the phone and calling. And for a lot of reasons, the answer you get from the primary care doc is often from their frontline staff, go to the ER for liability reasons and because they're not in the home. And I just thought I want to be on the other side of the phone. So I went to NP school, and I've really enjoyed, since 2014, I've been a nurse practitioner doing both primary care and palliative care. I worked for 2 years with Dave as a director of Arbor Palliative Care, which is affiliated with HOM, and it's just there's so much of a need. Palliative care is something that is misunderstood. There's an unlimited need for it, and I want to help you understand what that means and what the choices are and how to ask the right questions so that you can understand your wishes and what the options are out there. So the question that Chuck posed to me was palliative versus curative. And I say cure versus comfort, or is it possible that you can actually have both at the same time? So the definition of palliative is to relieve pain and suffering without dealing with the cause of the condition. The word means, its Latin roots are to cloak, or to cover, or to comfort. And one of the kind of common misconceptions of palliative and hospice, which is which comes first. All care that seeks to comfort is palliative. Hospice is the very last stage of palliative care, and it's actually a healthcare benefit that you choose. Palliative means lots of different things in different settings, and we'll talk about some of those next. But that's one of the common questions I get is, what's the difference between palliative and hospice? Hospice is a healthcare benefit. Again, you have to have 6 months or less life expectancy in a terminal illness. And palliative can work with people much, much further upstream. I think my hospice colleagues do amazing work. Hospice in Michigan has been around since before there was a hospice benefit. In the 70s, they were a volunteer organization. And so then when the hospice benefit became Medicare and Medicaid supported, they were already in place. And what they do is amazing. But what palliative care does is upstream, and it can partner with people whether they're receiving curative care or aggressive care or not. So that's one of the distinctions. I need my glasses. So my last point here is that if cure is no longer possible or desired, that's when you would opt for hospice. One of the other secrets is that a lot of times palliative care is a nicer sounding word than hospice. We joke about it. Sometimes people have a hard time hearing the H word. When I started in my clinical work, I was an aide down at Wyandotte Hospital, and I was on the hospice floor. And back then, in the late 80s, it was just the last few weeks. It was almost entirely cancer patients, and it was tons of morphine. People weren't really interacting much with their family, and it was, a lot of intense comfort care, and people passed quickly. Hospice has really expanded much further upstream into many, many more conditions. People are on hospice for sometimes a couple years, and a lot of people actually graduate from hospice and come back over to palliative because they don't progress as expected. So it's a much different climate for hospice, but still some people have that connotation. So a lot of people in palliative care are sick enough to be on hospice, but for personal reasons, they just aren't ready to make that change. But so palliative care can bring the same type of symptom relief and support to people who are not yet in hospice or never want to elect for hospice. So I think I talked about this slide already. So hospice is a set of services. You do have to be certified, usually by your own primary physician or specialist and the hospice physician. Two physicians have to agree that they say if an illness takes its natural course, most likely 6 months or less to live. And a lot of people outlive that mark because Dave has a great article actually. Stop at the back table, he brought an AARP article about, we've known anecdotally for years that the support of hospice and palliative helps people do better and live longer. And there's emerging research about that. And so Dave has a great article about how once you get into that higher level of supportive care, people are extending their prognosis. Palliative care is a medical specialty. So just like cardiology is a specialty, or endocrinology is a specialty for the treatment of diabetes or hormonal disorders, you can become a medical provider, a physician or an NP, and you can become certified in palliative care, which is relief of symptoms, whether it's on the hospice side or out in the primary care world. And then there are also other services out there that are called palliative. For example, there's some Medicare skilled home care agencies that have a palliative division. It's their same services, but they kind of have the brightest and the best nurses and therapists who are used to dealing with people with very advanced illness on their palliative team. So this is another thing that's kind of confusing, and I'm sure we'll get some questions in the Q&A about the different types of palliative care out in the community. But mostly, I want to help you today understand where to go and how to clarify your own wishes. When you understand your own values and wishes, that helps you ask the right questions, and then you can find the services that best fit your needs, in any community. So here's the question Chuck asked me. Let's say someone goes to the doctor, they're offered a certain treatment, it's a very aggressive treatment, you kind of are stunned, you don't really know how to ask for an alternative, you maybe aren't prepared with it, how do you even know how to sort through your options? I want to give you a little bit of a background on how people just kind of move along the conveyor belt. There was an excellent book called Extreme Measures by Dr. Nutik Zitter, N-U-T-I-K, Zitter, Z-I-T-T-E-R. And she talks about how if you don't make a choice and you just end up moving down the next step, the next step, the next step, she calls it the mechanized conveyor belt of more and more tubes and treatments. And some people want those, and sometimes they're a good short-term bridge until the body can heal and you get back to your usual level of function. But if that's not your wishes, the time to think about that is upstream. Some of the factors that really affect your choices are the fact that in medicine today, so I trained as a nurse, but I work now as a physician, so I kind of have credentials to see both sides. In medicine today, it used to be your own doctor knew you best, and you would make decisions for you one-on-one as an individual. And the way we are all on electronic medical records, and the insurance companies have a lot of stake, and they do a lot of data monitoring, and there's a lot of push to have everybody be what they call on guideline. And clinical guidelines are wonderful things. They help make sure that everyone stays to the highest standard of care, or the most beneficial standard of care for most people. And physician groups, and me as a nurse practitioner, I'm measured about how many of my people with heart disease are on a statin, or how many people with high blood pressure are under this number. It's gotten down to like a numerator and a denominator. How many people out of this type of a group are receiving this type of treatment? And that's how we're measured. Coming up, it's going to be how we're paid. You might be hearing about value-based payment. A lot of quality programs have different names. But the problem is that individuals, especially individuals with advanced illness, the same guideline that's appropriate for someone who's 68 and takes 2 medications is most likely not appropriate for someone who's 88 and takes 10 medications or 20 medications and has a lot of other conditions and maybe doesn't have the same wishes or values as that person who's 68. So there is a push that if you don't understand your own values and wishes, I'm not saying guidelines are bad, but I'm saying that you want to figure out what's unique about you. And I'll give you some good resources on how to walk through that. So that when you're offered treatment options that are on guideline, you realize that you have the right to advocate for yourself and be an exception. Guidelines are just that. They're not mandatory requirements, but if you don't understand that that's kind of the driver, is it's one size fits all, or what's best for most people most of the time, you very may well be an exception to that guideline, and the only way you'd know that is to know your own wishes and values for yourself, and then your healthcare provider can mirror your care to suit you. Okay. One of the things too is that the best question to ask is what we call about the benefit to burden ratio of a treatment. So I can't tell my patients what to do. Doctors can't tell you what to do. Treatments can be offered, but the best questions that I advise my patients to ask, so when I'm functioning on solely a palliative role, and I'm not the quarterback of the healthcare team. The primary care doctor is the quarterback, and there's an oncologist managing the chemo. In palliative, I'm there to manage the symptoms. I'm providing the pain relief medicines and helping them make the decisions. I will quite often help people sort through a list of their most pressing questions to ask during that very short healthcare visit. And one of the best questions is to say, what's the burden and what's the benefit? And you can really quantify this as how difficult would this treatment be for me to live with, best and worst case scenario, especially important for things like chemotherapy. What's the best outcome to expect? Some treatments, they might say, well, the best possible outcome for this treatment is to extend your life by 1 month. In research terms, that's incredibly significant, and they'll talk up that their treatment is best out there. And maybe if you've got, a daughter getting married in a month, you'd go through anything to live for that 1 more month to be at that wedding. I've seen that time and time again. But if you say, what is this going to cost me physically in terms of side effects and quality of life and the ability to spend my time the way I want, if no treatment is 6 months, and with a treatment that's pretty hard to deal with is 7 or 8, some people might opt out and say, I would rather take the time with supportive care and wait and see on the treatment. And then, ask what is the likely outcome with partial or no treatment. Partial treatment is another good option people don't think about. You don't necessarily have to take all of what they're offering you. And the example I use is that in traditional medicine or in traditional health care, it's like if you came to my house for dinner. If you come to my house for dinner, I get to decide what's on the menu. I'm going to make meatloaf, mashed potatoes, and green beans, and you can come, but that's really what I have to offer you. If you know your wishes, it turns healthcare more into like a buffet, where you get to say, yes, I would like this part. I want radiation, but no, I don't want chemotherapy. Or I want to try this for 3 sessions, but after, you don't necessarily have to just take what's on the menu as standard. You can customize it and talk with your healthcare provider about what would it look like if I did some of the treatment you're offering me, but not all, and how would that affect my outcomes? And then the best question I think I can give you today to ask if you're in a doctor's office and you're being told, some serious news and offered some hard choices, is because we cannot tell you what to do legally and ethically, many healthcare providers will answer the question, what would you do if this was your family? What would you do if you were in my shoes? Or, what would you tell your mother if she was in the same situation? And I do that for my patients all the time. So, you know your own mind and you know your own decisions, but if it were me, I would do this and here's why. But here are the other factors that you might want to consider. So that's a good way. Not everybody will answer that question. Some aren't comfortable, but most physicians I've worked with and collaborated with will share what they would do personally, and that's a really good piece of information to have. You may or may not be as aggressive or conservative as your healthcare provider too. Some healthcare providers want treatment at any extreme, and some are very, very conservative. So start to know what your healthcare provider's perspective is, but most of all, understand your own wishes. Okay. So I mentioned this a little bit. Doing nothing, or not having the conversation, or not really taking the time to understand your options, and then to define your wishes, and then most importantly to share them with your people who are going to be deciding if you're unable. Not doing that is actually choosing CPR, which is pretty brutal, and I want to say 5 to 6% success rate, and of those people, 40% have cognitive function. So what you see on TV and in the movies really does us a disservice. Some people want that, but other people, when they learn what that really entails, would opt out. There's a really interesting article. It's called How Doctors Die. I want to say it was in Reader's Digest for sure. You can probably find it online, but that was a very interesting look at what happens when physicians themselves are diagnosed with some of these serious conditions and what their choices are. And as a nurse in the ICU, I'm kind of a blunt person. I cracked a lot of ribs doing CPR on people that I know didn't want it because they didn't have their DNR documented, or a family member from out of state who wasn't really part of that conversation rushed in at the last minute, and I've seen those wishes reversed, which is a shame. And that's one of the reasons I went down the path I chose for my career, is that I think people should have an option And the more people understand your wishes, the more you have a chance to get your wishes followed. The other thing, I was just having a conversation yesterday with my current coworkers. Somebody sent in a form that was a DNR form. Those are really important if that's your choice. We really should call it DNAR, which is do not attempt resuscitation. Because DNR makes it sound like you just flip a light switch and you just say resuscitate or don't, and it's not that simple. But we were talking about where should it be filed and who should it be sent to. And it should be sent to this person and make sure so-and-so has a copy and make sure their chart has a copy. And I said, my palliative team of NPs, I built into our charting templates that do they have a DNR, yes or no? And if they have a DNR, yes, is it posted on the refrigerator? And that's one of the other tidbits I want to share with you. If you do feel like you don't want, or if you have someone in your life that they know, if their heart stops beating and they stop breathing, that they're at peace with that being their time. They don't want a breathing tube. They don't want CPR. They don't want defibrillation, which is the shocking. The place to put that document is on your fridge. Because fire departments, when I was a home health nurse, I got to know a lot of fire departments because we would be in the home with a crisis and call 911, and they would often, the fire EMS would respond. Fire departments do a lot of community education in certain communities where you can have something called the file of life, or some call it the vial of life, and you put it in your freezer. Has anyone ever heard of that? No? It's city by city. Not every city does it. But they're trained and they know. They go look in the freezer, and it's a list of their medications and a list of who to contact in case of an emergency, things you would want EMS to know about you. But if your city doesn't do file of life, just put it in an envelope and put 4 EMS on it and put it on the fridge. Because until it gets into the hands of the people who would actually have to make that decision to resuscitate or not, it doesn't really serve its purpose. So, and then the other thing people will say quite often is do everything. Do everything is a very common way to say, I want everything that could be a benefit. But I'm going to share some resources, one of which is the Conversation Project. It walks you through what does that everything really look like. Sometimes doing everything is things that are painful and don't really have a high success rate and have a lot of negative outcomes attached to them. It's far easier to say, I don't want that tube put in me, than to say, oops, now can we take that tube out of me? So that's where I would say do everything is something that if you want that, that's good, but you should really fully understand what everything means. And your decision makers should as well. I love your ringtone. So here are some myths. I'm going to talk a little bit. Do you have any questions at this point? No? Yes.
And hospitals ignore or not
Hold for the microphone, please.
I'm sorry, I did that on the fly. I just felt like I've been talking for so long, I want to take a question break.
Can a hospital ignore a do not resuscitate order? They do.
Legally, the answer is no. As someone who's been in the ICU and done CPR on many, many people, I told you I was more of a straight talking person. Here's the reality. If you die, you can't sue. But the out-of-state family member who comes in at the last minute and says, no, wait, do everything, can. And I've seen it. So I will say in my own personal experience, I've seen it. By law, they're required to follow your wishes. But that's why it's really important to have everybody understand them. I think it's getting better. When I was in the ICU, it was the late 90s, early 2000s. And I saw them overturned all the time. And it broke my heart. So we have a joke, us nurses, we're going to write no CPR and a tattoo right here because that speaks for itself. But yeah, so excellent question. Yes?
You said that not choosing results in the highest level of care. How do we choose a lower level of care?
Okay, good question. So the best process upstream is to start reflecting and identifying and documenting your big picture wishes. And that's where the best resource is the Conversation Project. It's linked here to my presentation. You can get something that's a legal document called an advance directive. And that has not only things like who you want to be your decision makers, it talks about what you do and do not want for healthcare. It's about a 30 or 40 page form. There's a state of Michigan form. Actually, I know Chuck is your email captain. I will make sure Chuck has the links to those forms that kind of walk you through step-by-step different options and who you want to make your decisions and what's your philosophy or outlook. When you're in a healthcare setting, every place you go is going to ask you about what we call code status, and it's really frustrating because right now there's not one enduring decision. There's something out there called POST, Physician Orders for Life-Sustaining Treatment, or POST. I think in Michigan it's called MyPost, M-I-P-O-S-T. And it's just started to gain ground here because it requires partnership between healthcare facilities like hospitals and nursing homes, EMS crews, and physician offices to make it one decision, one time that you can document your wishes. Right now, you'll answer the questions when you go into a facility or a hospital, and they ask you the questions, do you want to be resuscitated? And that's usually 4 things you can say yes or no to. And that would be CPR, which is chest compressions and mouth-to-mouth. Actually, for people in the community, they no longer even teach mouth-to-mouth because people were avoiding it just because of germ phobia, and they found it's just as effective to do compressions alone. So do you want someone to do CPR? Do you want a breathing tube? That's called intubation. That's the second option you can say yes or no to. The third is defibrillation, or the AEDs. Probably there's one in this building where you can put the pads on and get electrical shock to restart your heart rhythm. And then the fourth is medications to support blood pressure and heart rate. And so a lot of people who want more conservative care would say, okay, you can do CPR, but I don't want a breathing tube, and you can give me medications, but I don't want to be shocked. Those 4 do work together in tandem, but the breathing tube in particular, if it goes in, it can be very hard to take it out. So that's one of the wishes that it's really important to kind of understand if you wanted that or not. So that's the most specific way to get your decisions known. And the Conversation Project was started, it's a nonprofit, was started by I think she was a reporter, somewhere in the news and the media, and her mother went through this journey, and she said, I want other people to have better resources upstream. So I would direct you there to start about your wishes and values, and then I will make sure Chuck has the links to the advanced directive form for the state of Michigan. You don't need an attorney to fill it out. You can certainly talk with an attorney if that's part of your planning team, but you can just fill it out for free and make copies and share it with the people who are your decision makers. And then the most specific is your DNR form. And there's a link to that too. There's a state form. You can get very specific on what you do and don't want. Okay. All right. I'm looking at the clock. I'm going to move forward. So, oops. Let me go back. Nope. You told me, Dale. I'll get it. I do want to talk briefly because when I work palliative care, I work side by side with hospice. Hospice is a wonderful benefit. The way I describe it, it's kind of a hokey description, but if you were on a tropical island and you had all your healthcare team on this tropical island, your primary care doctor, your oncologist, your cardiologist, palliative care is like a food truck that brings really good food to help sustain and resuscitate you while you're going through all these treatments that you do or don't want, or while you're getting traditional care. It basically joins your existing team. Hospice would be the equivalent of a big cruise ship that comes and everything is all-inclusive. It's a big healthcare benefit. It covers medicines, equipment, tons of healthcare providers coming to your home. But you can choose what you do and don't want, like that buffet-style approach. That's the hospice healthcare benefit. But just like a cruise ship, you can get off and go back to the island and have palliative care support in a more limited role. So Dave's heard that example many times. But hospice is not expensive. It is 100% covered by Medicare, and it does include the meds, the equipment, the supplies, and respite care for families. So someone can go into a nursing facility or a hospital for 5 days so the family can get a break. Hospice is not just for cancer. We talked about it being for many, many more conditions like heart failure, COPD, dementia. It's not a one-time, one-way decision. That's the thing that I think is most scary for people, is if someone says you're eligible for hospice, it brings up all these feelings of, oh my gosh, I'm heading down a path now from which there's no return. And we try to help people understand that your body's on this journey of illness no matter what. You can take treatments or not, you can choose hospice or not, but things are going to progress the way they're going to progress. If you look at hospice, it's more of a healthcare benefit that you've already paid for. It helps take that fear factor out of it. And you can sign into hospice. And then I've had many patients that were cancer patients, and all of a sudden a new drug came out or a new study came out they were invited to participate in, and they chose to opt out of hospice and come onto the palliative side. And so I continued to prescribe all their comfort medicines while they came back to their primary care doctor and oncologist care, and they participated in the study. One patient in particular felt like that was how she was going to make meaning out of her illness, is that she wanted to participate in a study that could help other people, which is wonderful. So you can come and go from hospice. And then it is actually not a death sentence, and Dave has one of the great research-based articles, and I've got a link to another one about how hospice and palliative care, receiving that supportive treatment on either side of the coin, the palliative side or the hospice side, really will help people live longer, research shows. So here are some places that you can go to actually research your options to be better informed when you do go to those healthcare appointments, or if you are surprised by difficult decisions. Hospice of Michigan has a great website, hom.org/eligibility by major illness, and you can kind of explore what does hospice eligibility look like for those conditions. If you want to know, is palliative care right for me, there's a great website called getpalliativecare.org. It talks much more detail about what palliative care is and is not, and it has a registry of places that you can receive palliative care. I think you just put in your zip code and it tells you which programs are around you. And then my favorite resource is the conversationproject.org, just because my passion is getting upstream. I do like those, really intense situations and helping people that have advanced illness feel as best they can, but my mission is to get this message out to people before they really need it. And I think that conversation project even starts with things like, if you had a serious illness, would you want to know the details? Right? If there are a lot of Chrysler folks in this room, I've known a lot of engineers in my life, and they want to know how many millimeters is my artery pre and post the balloon stent, right? I understand engineers quite well. Some people don't feel that way. Some people, and a lot of it's culturally based on what is your healthcare culture of your own family, and then if you come from a different region of the world, a lot of those families, the person with the serious illness chooses, they don't want to know all the details. And so it starts even at that high level of reflection of how much do I really want to know? So, and these are just the big font websites in case you want to write them down. Here's another tidbit I want to give you, and then I'll finish up. How to get the most out of your primary care visits. The reality today, I do house calls, which I love. I get to spend about 45 minutes with my new patients, about a half an hour with my existing patients on follow-up visits. But when you're going to a traditional office, they're booked for 15 minutes, just because that's the reality of healthcare today and how things are. Always know, people that I care for in their 80s and 90s especially, the doctor was it. You didn't question it. They said, take this pill. Okay, what's it for? I don't know. They just were raised, never questioned. Things are so different now. Even if it feels uncomfortable to you, I invite you to speak up for yourself, or if you've got someone that you're going to visit with, and let your PCP know. Prepare, jot down your questions that come up between visits. And I've had some people come to me with a list of 20 questions, and I'll say, well, I wish we could get to them all, but what are your top 3? What are your top 3 most important issues that, because they have their own agenda. They want to check your labs. They want to look at your vitals. They want to do their exam. But bring your own top 2 or 3 priority questions to that visit. Bring someone with you, or probably most of you guys are going to be accompanying somebody else to a visit, because when you're the patient, it's very easy to be distracted or worried or nervous, and you forget what the person said, or you forget to ask your question, and that person that's not the patient can help jot down notes to remember after the visit. And then most practices have what's called a portal. So if you love getting on the internet, you can ask your practice for the code or how to access the portal, and you can usually see your lab results. You can see summaries of your visits. That's a really good way to kind of refresh yourself and stay current on your treatment plan. Okay. This gets into the rest of my presentation, which was dual, and it's there on the website. So it goes into lots more information about what types of care are out there. I see. Do you have a question, or are you telling me time? Okay, yes, sir. Yeah, I think I get the gist of your question. He's asking about knowing when to use long-term care versus when to use hospice or other services, is that right?
Yes.
Yeah. I am not an expert on long-term care, but that each plan is so different. My understanding is that it's basically to help support and pay for the cost of care that you need, and they all cover different things, but they cover, the ones I'm most familiar with, cover a lot of the non-skilled things that you might need at home, like someone to come help you with bathing or dressing or grocery shopping or things like that. Hospice and palliative care, I've worked and cared for many, many people who are receiving long-term care benefits. So I don't know your plan details, but most of the plans that I've ever cared for patients on, we work together. They're not exclusive. So my advice would be identify what is exactly in your plan. Hospice and palliative should not interfere with that, but I would direct you back to your own, because this is basically another level of health care, whereas long-term care is to provide like housing or a facility, or if you need another level of care. So I don't think there is usually a conflict, but I don't want to speak to your specific plan. Yep. No, that's a great question. So palliative care, oh, thank you for the reminder. The question from the web was, how is palliative care paid for? I'll talk about two types of palliative care that are the most common out there. One is a medical specialty palliative care, where it covers a healthcare provider, a doctor or nurse practitioner, to either visit you in the hospital, or some of them have outpatient clinics, but most people who need palliative care are too sick to get to an outpatient clinic, so a lot of it's provided in the home as a house call. That is billed just like your specialist is covered. So if your healthcare, would pay a certain amount to a cardiology visit with a copay, then palliative care is covered just like the doctor or the nurse practitioner goes out and sees you, and then they submit the bill to Medicare just like a cardiologist would. So however your specialist visits are covered under your plan is how the medical specialty of palliative care is paid for. The home health agencies, the Medicare skilled home health agencies that have a special palliative care division to care for their sickest patients, that's paid for just like Medicare skilled home care. And that's covered 100%, and they pay for it on 60-day episodes. And what you really need to have going on with your illness is something that's high risk enough that it might put you in the hospital. Medicare finds you much cheaper to care for at home than to go back to the hospital. So those conditions where they'll pay for a nurse, for a physical therapist, for a short-term home health aide are things like heart failure, diabetes, COPD, advanced lung disease, things that having someone come to your home, and from that palliative group in the Medicare skilled home care, Medicare pays for that service. And the people who have advanced illness usually have enough, I call them like pots that simmer on the stove. Everything's not hunky-dory, there's usually low-level problems that are kind of simmering, and usually there's enough ongoing problems to warrant continuing that for usually several months to years, that Medicare skilled home care palliative focus. How am I doing for? Yes, sir.
Question right here.
I've been paying MetLife for long-term care for a number of years, and my feeling is they want to get out of whatever commitments they have to me. I don't know what to do.
Yeah. There is usually an ombudsman or a patient advocate division of the insurance company to help you navigate your benefits. If you call the number on the back of any insurance card and say, I need help understanding my benefits, and push them to say what is covered. Usually the thing that's most valuable is unskilled care. Skilled care is covered by Medicare or a doctor's visit. Unskilled care are those people that are like nursing assistants that would come and provide bathing assistance, dressing assistance, things like that, but those are expensive. So I would recommend if you call the number on the back of your car and ask for help understanding what's covered and what's not, it's probably going to be a long phone conversation with lots of hold time. There are also, if you have a very expensive healthcare conditions, there are groups now of people whose job it is to be what they call a patient advocate, and they actually make money from the percentage of what they save you. So people that have very expensive healthcare conditions and lots of hospitalizations, there can be so many things in those bills that are billed that maybe shouldn't be, or double billed, or billed incorrectly, that they make their money by combing through your benefits and understanding exactly what should and shouldn't be paid for and fighting for that. And then they're they're paid through a percentage of what they save you. I don't know if your healthcare is that expensive, but that's out there for the people with the most expensive healthcare.
If I can be able to allow all the speakers and all the questions, Donna has about 5 more minutes. She said she will be there afterwards. Can we hold the questions, please, until she concludes? It's done, thank you.
Actually, this part of my slides gets into the second half, which talks a lot more about types of care at home. I can talk about that for 5 minutes, but I think that the resources, the slides are pretty dense. So this is the skilled home health care, where Medicare pays to keep you out of the hospital when you have a high-risk condition. Private duty is what gets paid for out of pocket or paid for by long-term care, or the Veterans Aid and Attendance Benefit. If you're not aware of the Veterans Aid and Attendance Benefit, there's a bureaucratic set of hoops to jump through, but if you were an active wartime service member, you and your spouse, it's money, it's just cash, and then you get to spend it on whatever is most appropriate. It doesn't have to go, and you can spend it on private duty health care, you can spend it on transportation, you can spend it on food. So if you're a veteran or have someone in your circle that is a veteran, I really encourage you to seek that out, and I've got resources at the end. The other best benefit is your local area agency on aging. Have you guys interacted with that at all? Okay. They're like the senior resource library. I love them. We actually had their pamphlet in our open brochures. Like, I hand their information out to everyone I come across because they are the experts on what's available in your region at low cost or free to you. So if you haven't already contacted your area agency on aging, I encourage you to do that strongly. And then if you are doing something where you're having friends and neighbors kind of be your primary caregivers, I do recommend people have a backup plan. And so a lot of people will kind of find a private duty agency. They are quite expensive, but you usually have to get signed up with them so that if your friend or neighbor has a car trouble or is sick and can't help out care for the person that really needs private duty help, you at least are signed up with an agency that can be like your backup if you don't want to go with that as a main plan. And then these are a lot of wonderful free or low-cost services for adults. Michigan Home Health Services, that's also called a chore provider program. That's usually for people who are on Medicaid. The Veterans Aid benefit, I talked about that. And then you can learn about many, many more services in your area through your agency on aging. That's my last slide. This is a good one. This is what I'm going to close with. Medications are so expensive. That is one of the key things that I deal with my patients. I've been known to prescribe something as a 40 milligram pill and tell them to take a half a pill every day to cut their cost in half because the pills can be so expensive and the inhalers can be so expensive. So 2 things. Benefitscheckup.org is like a self-checkup. It asks you questions and points you towards some resources that you might qualify for and not know about. But your pharmacist is often stopped from offering you a generic alternative by the laws and insurance rules. But if you ask for a generic option, then they can discuss it. And every healthcare provider has only a few things they really want branded. Always ask for generic because they cannot suggest quite often. Okay, here's a quote from David Bowie. Aging is an extraordinary process where you become the person you always should have been. I love working with people who have such wisdom and experience. It's been so rewarding, and I'm looking forward to the other speakers, and I'll be here at the end. But they'll share my email information too. If you have other questions, I'm happy to respond to your individual questions that way and keep the conversation going. So, thank you.
Medicare, how long will it pay for palliative care?
So Medicare pays for palliative care either as a specialist. So if you're, whatever plan you're on, Medicare covers 80% of a doctor's visit, and then the remaining 20 you either pay for out of pocket or you have a secondary plan. So however your combination of regular Medicare plus your possible secondary insurance pays for like a cardiologist visit or an oncologist visit, the palliative medicine is paid for just like any other specialist. And then if you have one of those simmering on the stove conditions where they want to keep you out of the hospital, and Medicare pays 100% for skilled home care, which is a nurse, a physical therapist, other services that come. Those are the 60-day at a time.
Follow-up question. Medicare sometimes will only pay for a certain amount in a period of time. You know, 3 months, 6 months, once every number of visits for a year,
Mhm.
and then you have to wait till the next.
Yeah, some plans,
Get my chest.
yeah, if you're in an Advantage plan or something that's like a shared risk plan, you pay them a premium and they're responsible for all your healthcare costs. So they will do, like an HMO will do, and they'll say you have 10 visits in 3 months. Quite often, if you show a higher need, we can call and ask for additional authorization. We just have to say why and make your case. Because trust me, you're much cheaper to care for at home than having a hospitalization. So if you're coming up against that limit, but there are still things going on, ask for your care provider to get an additional authorization for more visits. And we just usually have to explain what's going on and what's the risk. And we can quite often, and not all the time, I'd say about 3/4 of the time, we get additional care authorized.
Okay.
Good. Thank you. Is that
No, I just want to ask,
last question? Go ahead.
do you have a printout of your slides?
Let me,
Printout of your slides?
I'll cover that.
Okay,
Good.
he will cover that.
Good.
Thank you.
It's actually on the note, hello everybody there on the webinar also that I was given to be sure to mention. There is no printout of the slides. They are on the website, so ncro.org. And I'll tell you what we'll do. We have the emails for all of you. I will send a link. Somebody on the team at some point will send a link to the group. Okay, I'll blind copy of the link to the site. But hopefully you've been on. How many have not been on the ncro.org site? Have not been. Okay, so just a couple. Thank you. Anyhow, it's there on the site. All three of them. John, pardon?
How many people don't have computer access?
Yeah, how many people don't have computer access? Good. I think everybody does because you all signed up online. We did send out postcards. No, don't hear me. We sent out postcards to the 300 or 400 people who we don't have their email addresses. To my knowledge, none of them signed up to attend today. So everybody here has access. But anyhow, please have a look. We want to help you. We'll send the link, okay?